The story starts here with the foot of a newborn child. The foot is little more than a bag containing cartilaginous tissue. It has no weight-bearing function and no visible longitudinal or medial arch. The rudimentary tarsal and metatarsal bones are visible in this radiograph of a 6-month-old child. The large gaps between the bones will eventually form into the relatively tightly packed joints of the adult foot. The foot of a 1-year-old is ready to walk, and the maturing nervous system is able to manage the difficult task of transferring weight from one foot to the other, allowing forward progression. This is an X-ray of a 3-year-old child. The centers of ossification have expanded. The foot has grown in length. In fact, the foot almost doubles in size during the first year, growing at the rate of 5 centimeters per year, and the continuing steady growth through childhood and adolescence comes to about 1 centimeter per year. This is the foot of a 10-year-old, and it already has many of the characteristics of the adult foot. This foot and the associated nervous system is capable of fine movement tasks, as shown here by a gymnast on the balance beam. The normal foot can be characterized in the sagittal plane as a hinged beam that is cushioned at key points of contact with the ground. There are fat pads at these contact points, which are quite thick in the heel, averaging about 25 millimeters at the thickest point. Under the metatarsal heads, the fat is much smaller and thinner, averaging only about 5 millimeters in thickness. Fluoroscopy allows us to see the deformation of the heel pad during contact with the ground, often averaging 50% deformation. The metatarsal fat pads are invested in the long flexor tendons, and they migrate as the toes flex and extend. The position of the toes are maintained by the combined action of the flexors and extensor muscles and the intrinsic muscles, which are contained entirely within the foot. In the normal foot, these intrinsic muscles can be clearly seen in magnetic resonance imaging, occupying compartments in the forefoot. The flexors of the hallux are shown here, and the interossei can be seen here. In the normal foot, there's a large range of motion at the talocrural joint, allowing plantar flexion and dorsiflexion. The subtalar joint allows the foot to pronate and supinate, part of what gives the foot its name as a mobile adapter. During walking, the normal human foot manages the impact of the foot with the ground, accepts the full body weight during mid-support, and provides propulsion. Using an instrument called a force platform, we can measure the forces during ground contact, called the ground reaction forces. At foot strike, these are typically about 120% of body weight. During mid-support, the forces fall slightly, as both feet are in contact with the ground. Finally, the foot provides a propulsive force to regain the momentum lost during contact. After a peak of about 120% of body weight, the force falls rapidly to zero as the foot leaves the ground. The force platform can also measure the shear forces in the plane of the floor. When the foot is braking, the force is directed backwards on the foot. During propulsion, the force acts forward on the foot. Here we see peaks of first braking and then propulsion during the contact phase of the foot with the ground in walking. When we look at the foot strike from the back, we can see early pronation, followed by supination as the foot leaves the ground. Walking on an uneven surface brings out the mobile adapter, the subtalar joint, allowing the foot to negotiate an uneven surface while maintaining balance and propulsion. Instead of just measuring the total force acting on the foot, it's possible to measure in smaller and smaller regions, until eventually we're measuring the pressure exerted on small regions of the foot using a pressure distribution platform. Here you see the results of the force platform on the left and the pressure distribution platform on the right. Notice how we see the concentrated loading in the heel and underneath the second metatarsal head, and also the loading at the hallux during toe off. When we see the pattern in 3 dimensions, here is a posterior view of a right foot, you can see the unevenness of the distribution of pressure underneath the foot. It's possible to summarize the entire contact with one peak pressure distribution shown here. This can be broken into anatomical regions, allowing us to calculate the peak pressure in every region of the foot. This is useful for comparing one patient with another and putting into the patient record. If we measure the ground reaction forces during walking barefoot and then walking in shoes, there is very little difference between the two patterns. The much more interesting interface is that between the foot and the inside of the shoe. Here you see a flexible matrix of pressure transducers being put inside the shoe, and this allows us to measure the effect of footwear and to measure directly the pressure under the structures of interest with a given footwear intervention. Individual sensors respond as shown here by a press of the thumb on the sensor matrix. Here we see a patient walking with insole sensors in both shoes. The patient walks freely and we collect often up to 30 foot strikes in each foot. As the patient walks, it's possible to visualize the pressure under different regions of the foot. The cool colors here are the low pressures, and the warmer colors are high pressures. Having diabetes for a number of years can cause alterations in foot structure and function. One consequence is a reduction in the range of motion at joints throughout the body, thought to be a result of non-enzymatic glycosylation of connective tissue. This is particularly common at the first metatarso-phalangeal joint, and it leads to elevated pressure underneath the hallux during the late stages of gait. Here we see the pressure distribution from a patient with limited joint mobility of the first MP joint, and you notice the elevated focal pressures underneath the hallux in the late stages of support. In contrast to the easily visualized muscles of the forefoot that we saw earlier, the forefoot of an age-matched, densely neuropathic patient shows almost no muscle. The atrophied areas are infiltrated with fat. It is believed that an imbalance of flexor, extensor, and intrinsic muscle activity can result in the proximal phalanges being dorsally displaced and in clawing of the toes. This concentrates pressure on the tips of the toes and on the dorsum over the proximal interphalangeal joints. When this patient walks, the toes don't participate in the weight-bearing process until very late in the gait cycle. You'll notice a high concentration of pressure underneath the second metatarsal head, and finally, in late support, the toes participate briefly. Another consequence of clawing of the toes is that the fat pad, which as we saw earlier was invested in the flexor tendons, gets displaced anteriorly and moved away from the bony prominence that it was designed to cushion. This can be seen in MRI scans of the feet of patients with clawed toes. The thickness of the fat pad directly under the metatarsal head is less than that of the fat pad anteriorly. One of the most severe consequences of diabetic neuropathy for the foot is the so-called Charcot's neuroarthropathy. For reasons that are not well understood, dislocation of joints and fragmentation of bones occur, leading to major disruptions in the anatomy of the foot. The new bony prominences on the plantar surface become focal areas of high pressure during gait and prime sites for ulceration and infection. It is widely believed that elevated plantar pressure is a risk factor for ulceration. These peak pressure patterns are some of the pressure distributions that are commonly encountered in clinical practice. You see concentrations under different anatomical regions, and they're not necessarily the same on the left and right foot of the same individual. Here, a first metatarsal head peak pressure. On the left, the dynamic pattern, on the right, the peak pattern. Pressure distribution here concentrated under the second metatarsal head. In this foot, there's pressure underneath the first and the fifth metatarsal heads, and underneath the hallux. Notice that forefoot pressures are almost always greater than those in the rear foot. This patient has focal areas of high pressure at every single metatarsal head. It's not only bony prominences that lead to elevated pressure. This is a patient with chronic callus, and this needs to be regularly removed because, as you see in this pressure distribution, the areas of callus cause elevated local pressure underneath the forefoot. Typically, these areas of hyperkeratotic tissue are removed by sharp debridement, and this needs to be done regularly. We're not entirely sure what leads to the deposition of hyperkeratotic tissue. Here the patient walks over the pressure platform again after the callus has been removed, and you see the dramatic difference in the pressure distribution underneath the forefoot. A direct comparison of the pre- and post-debridement values show you how important removal of callus is. Patients with prior surgery, including partial amputation, are at particular risk for reulceration because of the redistribution and altered biomechanics that occurs. Here we see a patient with a Lisfranc amputation walk across the pressure platform, and you see the dramatic concentration of high pressure underneath this patient's stump. Here is the pressure distribution underneath the foot of the patient with the hallux amputation. Notice that the pressure underneath the first metatarsal head is considerably elevated. In order for a typical plantar neuropathic ulcer such as this to heal, offloading of the damaged tissue is vital. The clinician has many options to achieve this result, but the gold standard is the total contact cast, where the foot and leg is encased in a plastic cast after careful padding of the bony prominences. The patient can walk, and as we see from this pressure measurement inside the cast, the ulcer area is unloaded. Typical healing times in a total contact cast are of the order of 6 weeks. And here we see the ulcer between cast changes healing effectively in a matter of approximately 4 weeks. Total contact casts are effective partly because they cannot be removed, and some have suggested that other forms of unloading should be made irremovable. Another option is the load-relieving dressing, which is a combination of wound dressing and load relief. This isolates the area of the wound and relieves the all-important mechanical pressure to allow healing to occur. It is often said that healing neuropathic ulcers is the easy part of diabetic foot care. The difficult and complex part is preventing ulcer recurrence. Some studies have reported up to 100% recurrence rates at 3 years. Therapeutic footwear is widely believed to be a key component in the prevention of ulcer recurrence. The footwear is typically extra depth to allow insoles and pressure-relieving devices to be put inside the shoe. Pressure underneath an object on a rigid surface is high, and this pressure can be reduced by cushioning, such as soft foam. As the patient walks on a hard surface, you'll see elevated pressure laterally. The cushioning as they tread on the soft surface is apparent, and the high pressure returns again when they're back on the hard surface. Another major mechanism of footwear intervention is redistribution of the load. Intervention that moves the load away from at-risk prominences, such as the metatarsal heads, backwards to load the metatarsal shaft, which is better able to take load. In most clinical situations, the shape of the foot is used as the basis for a therapeutic insole. A mold is poured on a foam impression, and material is molded over a positive impression of the cast. The resulting insole cushions the load underneath the foot. But shape alone is not sufficient to provide pressure relief. Combining shape and the measurement of pressure will result in a much more effective intervention. Here we see a contour representation of pressure and shape. These can be combined into a single display that a computer can then use feature recognition to produce an intervention in the insole which is suitable for computer manufacture. The CAD/CAM file is then transferred to a tool that carves out the features that have been designed in the computer program into a final custom therapeutic insole. Experiments have shown, through in-shoe pressure measurement, that insoles made on the basis of shape and pressure are significantly better in offloading bony prominences in the forefoot than insoles made by shape alone. Even the best footwear is only effective if it's worn, and studies have shown that only 20% of people report regularly wearing their footwear. And the regular wearing of prescription footwear has been associated with reduced recurrence of plantar ulcers. Inadequately designed or ill-fitting footwear can also cause ulcers. Various authors have reported that between 21 to 76% of the ulcers that they have seen were directly caused by footwear. One example is this dorsal ulcer on the fifth toe caused by this young patient wearing pointed, poorly fitting shoes with an elevated heel. In the past, footwear design has been more of an art than a science. Recently, attempts at modeling and measurement of material properties have led to a much more scientific approach to footwear design. Here we see a finite element model of the heel in different forms of footwear. This allows us to measure the optimal reduction in pressure that can be achieved through various attempts at alterations in the design of the footwear. In this more complex three-dimensional model of the foot and the shoe, the placement of the metatarsal pad is explored. The model has shown that the placement of the metatarsal pad in relation to the metatarsal head is critical in reduction of pressure.